Healthcare is confusing. Payer policies change, regulations are modified, reforms are proposed. We're breaking it down for you here on Inside Healthcare from Fulcrum Strategies. Today on the program.
If you're going to want Americans to get healthier, should they have access to nutritionists? Should they have access to good science about healthy food? Absolutely. Well, then, how is that going to happen with the Medicaid cuts that are taking place?
There are no cuts to Medicaid.
Sir, that is an absurd.
Welcome to Inside Healthcare. I'm Matthew Handley. This is the new podcast from Fulcrum Strategies that focuses on the healthcare issues that matter to you and your practice. Our commitment to you is to break down information in a clear and concise manner, and we know our listeners are busy, and we want to make sure that you stay informed. So let me welcome in our host, the President and CEO of Fulcrum Strategies, Ron Howrigon. Ron, hello.
Hello. It's great to be doing this again and to be behind the virtual microphone, if you will. So I'm looking forward to this. Thank you.
I am too. There's just such a plethora of information out there, and you often use the analogy of drinking from a fire hose when you're training new folks here at Fulcrum Strategies. And unfortunately, our physicians go through that all the time. Regulations change, reforms get proposed, as I mentioned there in the intro, and we want to make sure that our clients and prospective clients and just all physicians and the public in general are informed about these things that are going on. So, as I mentioned, we want to talk about issues that are important to physicians' practices, and we want to begin with one that's been in the news this last couple months, and that is changes to Medicaid from the big, beautiful bill. Ron, last week, Health and Human Services Secretary Robert F. Kennedy Jr. Was in front of senators in Washington in a hearing. He had a couple of very direct back and forths with a couple of them, and in one instance, he very emphatically said that there are no cuts to Medicaid as a result of the big, beautiful bill. Let's start there. Was that an accurate statement by the Health and Human Services Secretary?
The short answer is absolutely not. There is no unbiased entity out there or study that doesn't believe that the cuts to Medicaid were significant. I mean, it's almost $800 billion over 10 years, according to OMB, and that it's not going to affect millions of people with Medicaid coverage that will lose that coverage. So to say there's no cuts to Medicaid is not accurate at all.
So what's changing then with Medicaid? Does it have to do just with the funding, or as we keep hearing from the current administration, they want to go after waste, fraud, and abuse? So is it getting people off the rolls, or does it have to do with the money or the things that Medicaid covers, or a combination of all three?
It's all the above. I mean, you don't find $800 billion without dipping your hands into a lot of different coffers. The major parts are getting people off the rolls, the work requirement. That's a huge part. That's going to impact an awful lot of people. The having people certified twice a year is going to impact people and catch people from that. There's a lot of talk about fraud and abuse. And there's some things in there that are trying to get at fraud and abuse. One of the things to understand, though, is the fraud and abuse is not a huge amount of money there. Okay. In total, fraud and abuse in 2024 is estimated to be about $31 billion. That's if you could get rid of 100% of it. That'd be a little bit like the IRS saying we're not going to let anybody cheat on their taxes. Well, you're never going to get completely there. So $31 billion, if you could get rid of 10% of that, that's $3 billion. That's real money. But the big part are the work requirements, some of the change in the funding, the recerting every 2 years. That's why everybody that looks at this thinks we're going to lose somewhere around 8 million people with Medicaid coverage are going to lose it.
Several states started covering the GLP-1 drugs in the last couple of years. Are those going to no longer be covered because of these cuts?
Yeah, I haven't seen anything definitive on that. I know everybody's taking a look at that because they're massively expensive. Mm-hmm. And there's definitely philosophical arguments. Is that a lifestyle drug, et cetera? There are other arguments on the other end that says, especially with something like Medicaid, governmental covered insurance, that there's a good investment there because it offsets cardiac disease. And heck, there's even a study right now that Wegovy's trying to do to tie it to dementia, to help with dementia. So that's something that's going to be heavily looked at. GLP-1s are not where the big money is on Medicaid. It's how many people are covered. That's where the big money is.
Right. And I know in our home state, where our company's located there in North Carolina, several years ago, they finally got around to passing Medicaid expansion. And my understanding is there was a provision in that legislation that said if the federal money is changed, the reimbursement they're getting from the federal government, that the whole Medicaid expansion is going to go away. Am I understanding that correctly?
Yeah, absolutely. So when that was passed, part of what was in that bill was an automatic trigger because Medicaid expansion is almost exclusively like 97% funded federal. So there's not much state money there. But basically, the state put a provision there that said if that money ever goes away or even changes by a little bit, it automatically reverses Medicaid expansion. So in North Carolina, forget about the work requirement and that stuff. There's about 600,000 people that are going to lose their Medicaid coverage through Medicaid expansion. We know that's going to happen, and it'll happen when those changes take place. What in early 27, I believe.
Yeah, and I was going to say, in typical Washington fashion, it's going to take effect after the midterms.
Yeah, you gotta love it. And this is not a political party thing because both parties have done it. There's plenty of examples. A party touting this incredible piece of legislation that they can't let take effect until after the next election, or it might hurt them in the next election. If it was really that good, you'd want it to take effect right before the election. So I think that's a pretty telling piece on that there are going to be cuts to Medicaid. And again, somebody could have a philosophical discussion that says we're covering too many people, or that's a different discussion. I think part of for our purposes is, boy, if there are going to be that many people added to the uninsured, what does it do to the delivery system? What does it do to hospitals and doctors, et cetera, who will get caught in the crosshairs of this?
And we had just talked this morning in our morning get together with our staff at Fulcrum that the Affordable Care Act premiums are going to go up. So if these people are all going to get rolled off Medicare, granted it's not happening this year, can they necessarily afford the premiums for the Affordable Care Act? And I think that's a question that hasn't really been answered yet.
Well, you're right, and that has to do with I think the for 2026, the median increase to the ACA exchange plans is 16%. It was 7% last year. So having over 2 years, 23% trend is hard to stomach if it's going to keep going. And the big question is the federal government going to eat all of that through the subsidies? At which point, it's really not going to affect the individuals that much, or is a lot of that going to get passed down by either reduced benefits or increased out-of-pocket expense for the enrollees? That's a good question, and you bring up a good one of if a bunch of people are rolling off Medicaid and they can't afford the Affordable Care Act, then we're just going to see a massive spike in the uninsured population.
Yeah. So what happens to doctors in this scenario? Because we're looking at a bunch of people that either are going to roll off to be uninsured. Some of them might sign up for ACA plans. What happens to those patients when they walk into a doctor's office? How would you be recommending your clients right now address those patients in a few years if they get disqualified from Medicaid?
Well, I think it depends on who the doctor is, what their specialty is, and where those patients go. So let's take the easy one, or the hospital-based physicians, the ER physicians, the anesthesiologist, the radiologist. Nothing good is going to happen for those guys because there's going to be some fairly significant uptick in the uninsured, which means they're going to end up in the ER. They're going to receive services there that they probably would have or should have received somewhere else. And the doctors that care for them, the ER docs, the radiologists, they aren't going to get paid. We're going to go back to the days potentially where 40 million people don't have insurance and seek a lot of their care from the ER. So that's bad. The rest of the physicians, the more elective physicians, primary care, specialties, et cetera, they're going to have a tough choice to make. They're going to have patients that they have a relationship established with potentially that are going to suddenly have no insurance. And what do? Do they continue to care for them and do it for free? There could also be some positives to some of those practices. The patients that roll off Medicaid and onto an exchange plan, typically in most states, that pays better than Medicaid. So they'll maybe see that patient and get better revenue going forward. But that patient also might have a higher out-of-pocket expense where they used to have, almost no out-of-pocket expense with Medicaid. They might be paying 30% of the bill. That'll be problematic for them. So there's a lot of variables in this, and it's going to be hard to see really how the dust settles. I don't see, though, that overall This is going to be a win for physicians. It's definitely not a win for hospitals who are going to, take it on the chin, if you will. Again, cutting $800 billion of expense is $800 billion of revenue to somebody else. It's a closed system, and that system can't afford the loss of that revenue right now.
A lot has been made of what happens to some of these rural hospitals. Some have been saying they're going to close because of this. They're not going to be able to handle it. On the flip side, you might hear some people argue that, well, they shouldn't have been relying so much on Medicaid, but also they're serving the populations that can only get Medicaid in a lot of instances due to the income or disability or whatnot. Should we be that concerned that many rural hospitals are actually going to close, and what happens to those communities?
I'm personally very concerned because, post COVID, the rural hospitals, like a lot of other people in the economy, face some pretty nasty inflation. Inflation on labor, inflation on goods and services, et cetera. And they didn't get a corresponding increase in revenue. Post COVID, Medicare didn't suddenly give them a pile of money, neither did Medicaid. Commercial insurances didn't. So they're operating on massively thin margins. And this kind of a hit, this kind of a bump in the uninsured, could definitely push them over the edge. And I personally think we are going to see a lot of rural hospitals fail. To me, an interesting question societally is, do we still believe that every rural community deserves at least a primary level of hospital? If we do, then something has to be done. If we're okay with certain counties not having a hospital, people driving to it, that's a whole different thing, but it's not the way the system is set up now. The system's set up now where pretty much every county has some form of a hospital. Now, I will also say that in this debate, the Republicans will talk about the $50 billion put into the rural hospital, rural healthcare for hospitals, and $25 billion for physicians. And that's good, but that's 50 billion of 800 billion removed. That's not enough. That's to use a phrase I've used before, Band-Aids on bullet wounds. So I'm very concerned we're going to see a lot of failures of rural hospitals.
And kind of finally, at a broader level, what does this do to the healthcare economy? I know we've talked before about the fact that the healthcare space is pretty much the fastest percentage of GDP growth in our country, and that's at some point it's going to break. What does this do to the healthcare economy?
I don't think this is the breaking point. I do think it adds another stressor to it. It's almost like it's almost like playing Jenga, and you keep pulling bricks, and there's that one that eventually cuts it up. I don't think this is that one. It definitely makes it more unstable. One of the things that, for me personally, in the healthcare delivery space, that makes me concerned is we were very fortunate, I believe, in COVID, that we saw a number of things happen. We saw, rapid advancements in the care and treatment. We saw a vaccine brought to market massively quickly. All kudos to the people who did that. We also saw a delivery system that flexed well in capacity, in how it delivered care. And we handled what was an unexpected load of the delivery system very, very well. To the extent that we put more stressors on that delivery system and we have another event, whether that's another pandemic or, something of that nature, I don't think we're going to have that margin of flex before again. And we saw in other parts of the world where it didn't work. We saw Italy, we saw India, we saw a number of countries where they couldn't flex. And you had people in parking lots and, in tents and stuff. And that really concerns me, that we're chewing up whatever flex or margin was there. When we need it, it's not going to be there.
I want to bring it back to North Carolina as we conclude our program today. There was this weird thing that came out regarding a reimbursement cut to Medicaid. What's the deal with that?
It was weird, that's for sure. The state was going through a standard process called rebasing. And basically, they're starting with a budget. They're going to do a budget. And instead of saying, well, last year it cost us this much, let's add 5% to it, they ask each of the departments to go back and build a budget, build a base. Here's what I need. For a lot of departments, that's pretty easy. I know what my staff is to run the Department of Transportation. I can estimate what these costs are going to be. For Health and Human Services, which is Medicaid and that kind of stuff, it's a little bit harder because you have to predict medical expense trend. What is going to be the cost of healthcare for Medicaid individuals? So HHS went to the legislature and said, we've got a number of 813 million, something to that effect. And the legislature said, well, guys, you don't really have very good numbers to back it up. I'll tell you what, we'll put a placeholder here. We'll approve less than that. And what the legislator thought was going to happen is that HHS would come back with better numbers and they could maybe give them the rest of the money or most of it. And this is a pretty standard sort of negotiation between legislature, and that's not what happened. What happened was HHS, when we've got a new secretary of HHS, went back and said, well, if I don't have enough money, I've got to cut reimbursement. Expense in healthcare is price times volume. I can't cut volume, so I'm going to cut reimbursement. And they sent an email out to everybody saying, guess what, on October 1st, some physician schedules are going to get cut by 3%, hospitals by 10, behavioral health by 10. And people went, where the hell did this come from? And nobody saw it coming. The MCOs didn't see it coming. The legislature was caught off guard. So now we've, in essence, started this ticking time bomb with an October 1 date, and both sides got to figure out how to diffuse it or how to put the pin back into the thing, or we're going to see reimbursement cuts to at the lowest reimbursing type of patient in the state on October 1st, when most delivery system hospitals and physicians really can't afford that. And nobody knows whether it's going to get diffused. There's a lot of finger pointing on how it started, but time ticks away.
Yeah. I know one of the concerns is that with physicians, they get into medicine to help sick people. They get into medicine to serve other people.
Yeah.
Is there going to come a point when some of these government programs like Medicare and Medicaid, physicians just get fed up and say, I'm done with this, and they walk away? And that would break any private network. We've seen it happen with Bright Health several years ago.
Yeah.
Is there a chance the Medicare network or the Medicaid network could break because enough physicians say, I'm out?
Right now, with the trajectory on, I don't think the question is if it'll break, if the docs will stop doing it, but when. It's unsustainable in the current trajectory. You can't continue to pay less. You can't continue to ignore inflation and have people still do it. And I hate this answer. I've had a number of doctors ask me, why do they keep cutting me? And my answer is, that's a little bit like an abused spouse saying, why does he still beat me? And the answer is because you don't leave, because you're still there. And that's horrible, but that's what's going on. And so in one respect, I have enormous respect for physicians who continue to care for people that below cost. But at some point, for their own viability, they're going to have to say no. And that's going to come in either the form of them limiting how much Medicaid they do see and or not seeing it at all. And so we could fairly quickly get to a point where you've got a Medicaid card and it doesn't do you any good. One doctor said it's, and I don't mean to pick on this company. He said, it's sort of like having a Discover card. Nobody takes it. Like, yeah, it doesn't do you very good if you can't swipe it somewhere. That's one thing when you're talking about a credit card. It's a whole different thing if you got, well, where do I get care?
Right.
And the more that happens at the wrong time, the more that's going to push on the ER because that's the one place where they can't refuse it. And I think we run the risk of overloading and overburdening our ERs, which will make hospitals fail.
Well, Ron, that's about all the time we have. I wish we could end on a happier note, but I'm glad we're making sure that we're keep staying informed on this. We will stay on top of the reimbursement issue in North Carolina and bring you any updates if we hear them about whether or not that fee schedule will take effect on October 1st or not. If there's a topic you think we should discuss, let us know. We're both on Twitter and LinkedIn. You can also go to fsdoc.com. Ron, thanks again, and I'll talk to you soon.
Sounds good. Thank you, Matthew.